pericardial diseases, case-based approach. So first of all, I'd like to thank you for inviting me to give this talk. Actually, pericardial disease, it's a forgotten disease in the heart, but it's a common presentation of cardiac disease. So the pericardium is a rigid vascular fibrous sac composed of visceral layer adjacent to the epicardium and slightly thicker and richly innervated parietal layers. The pericardium probably function as a barrier limiting the spread of infection. Despite pericardium, it's protective against the infection, but it can be affected by pericarditis. So acute pericarditis is a relatively common source of chest pain that may be confused with coronary ischemia. And we will see in our cases, there is a lot of confusion between acute pericarditis and coronary artery ischemia, starting from chest pain, ECG changes, elevation of cardiac biomarker. So several evaluations are mandatory in the diagnostic workup for all patients presenting with possible pericarditis. So the etiology of acute pericarditis could be idiopathic, could be infectious, commonly in this era of COVID-19, could be viral, microbacterial, fungal, and purulent pericarditis. Could be due to autoimmune disease or after acute myocardial infarction, or secondary to neoplastic cardiac disease or lung disease, or secondary to uremia. And this is a diagnostic test, and the finding in this diagnostic test. By physical examination for patients who presented by pericarditis, mainly in early phase of the disease, you can auscultate pericardial rub, which is specific for acute pericarditis in early stage before pericardial effusion accumulated. From the ECG, you can see diffuse SCT segment elevation, BR segment changes, mainly depression. And by echocardiography, you can see some pericardial effusion. If this effusion increase in size, it can lead to cardiac tamponade. From chest X-ray, could be a normal finding, or you can see the classic pictures of water bottle heart shadow due to pericardial effusion. Also by X-ray, you can see some pleural effusion if there is associated pleurisy. In the blood test, you can see inflammatory marker in the form of a change in total leukocytic count, elevation of CRP or ESR, or if there is any bacterial infection, you can appreciate elevation of procalcitonin in patient with purulent pericarditis. There is another marker, you can get it from the blood test, which is marker of myocardial necrosis and marker of myocardial dysfunction. In marker of myocardial necrosis, classic elevation of cardiac enzymes, mainly if it is associated with perimyocarditis. Also, there is marker of myocardial dysfunction, I mean heart failure, either systolic or diastolic heart failure, like elevation of ProBNP. First case I will present today, 18 years old boy with no risk factor for premature coronary artery disease, presented by cough, high-grade fever, and chest pain. Admitted under care of pulmonologist as a case of pneumonia because the X-ray chest showed right-sided veiling and slight right-sided pleural effusion. And if you will appreciate here on the lateral view, you can appreciate consolidation with some sort of pleural effusion, which showed raising of the this consolidation to the axilla. It means right side consolidation associated with right side pleural effusion. High resolution CT chest was done for this patient and showed same finding, right-sided basal pneumonia with right-side pleural effusion. The pulmonologist requested ECG for this patient, and you can appreciate here there is significant elevation of SCT segment in lead 2, 3, and AVF. But the rest of the ECG, there is no significant elevation like in the inferior leads. Because of this elevation in the SCT segment in the ECG, they requested cardiac biomarker, including marker of inflammation and marker of dysfunction and marker of myocardial injury. Marker of myocardial injury, including significant elevation of high sensitivity cardiac troponin, significant elevation of CKMB, and there is marker of myocardial dysfunction, which showed significant elevation of pro-BNP. And you can appreciate the marker of inflammation here, which is CRB, significantly elevated 51, and the upper limit of normal 0.5. Because of this ECG changes and the elevation of cardiac biomarker, they request echocardiography, and you can appreciate here in the upper panel, long axis parasternal view, short axis, and apical for chamber view in the lower panel. And you can appreciate here there is no segmental wall motion abnormalities indicating myocardial dysfunction or myocardial ischemia, but you can appreciate hyperechoic pericardium, mainly at the inferior and posterior segment in the short axis and the long parasternal axis and apical for chamber view. So what the differential diagnosis here? Definitely, we will put the differential diagnosis of my acute myocardial ischemia in the form of MI, and this is rare possibility. And the second, which is perimyocarditis, and this is the logic etiology. So for this, you have to rule out significant coronary artery disease for it, despite the age of the patient, 18. So we decided to do coronary angiography, and here you can appreciate the left coronary artery and right coronary artery showed no obstructive coronary artery disease. Cardiac MRI done for this patient, and this is in cine view. You can appreciate nearly normal left ventricular function, no regional wall motion abnormalities or global wall motion abnormalities. But in this view, which is T2 with fat suppression, which is called the edema imaging, showed increased brightness of the lateral, anteroseptal, anterior, and the inferolateral wall of the left ventricle, indicating myocardial edema associated with pericarditis. So this is case was diagnosed after the cardiac MRI as acute perimyocarditis, and the acute MI was ruled out already by coronary angiography. And this is very interesting delayed enhancement image showing enhancement of the anterior lateral wall and the overlying pericardium, indicating acute perimyocarditis. So the treatment of this patient was antibiotic for pneumonia, and for perimyocarditis, we give this patient ibuprofen in the recommended dose, colchicine, and BBI. And the patient showed dramatic improvement after the non-steroidal BBI colchicine and the antibiotic for pneumonia. And this is excellent echocardiography was done 4 weeks after recovery from acute perimyocarditis and the pneumonia. Second case, also male patient, but the age now 36, known to be hypertensive and smoker, presented by chest pain 4 days in duration with maximum intensity day before admission. This is his ECG, and you can appreciate here poor R wave progression from V1 to V3 with mild ST segment takeoff, mainly in V2 and V3. So cardiac biomarker was done because of this ECG changes. High sensitivity troponin 600, CKMB 12, CK total 156, proBNP significant elevation 5106, and here the CRB significantly elevated. So there is 3 biomarker positive, one for myocardial injury, one for dysfunction, myocardial dysfunction, and the third one, which is biomarker of increased inflammatory response. Because of the ECG changes and the chest pain and the elevated cardiac biomarker, including troponin and proBNP, we did angiography for this patient, and as you can appreciate here, no any obstructive coronary artery disease. Here the echo was done immediately, and you can appreciate here there is anterior pericardial effusion, thickened hyperechoic pericardium, mainly in the area of the posturociptal and the inferior wall in upper and lower panel. Apical fourth chamber, you can appreciate the pericardial effusion and the hyperechoic pericardium here, and lateral wall. Cardiac MRI showed the same finding, wall motion mainly at the posturociptal inferior wall with also second pericardium over this segments. So this is comparison between the echo in short axis and cardiac MRI, and you can appreciate the posturociptal segment hypokinetic in the echo and cardiac MRI. So this is T2 edema image showing diffusely increased myocardial brightness with patchy of variation indicating myocardial edema, delayed enhancement image by cardiac MRI showing diffuse faint myocardial enhancements and the overlying pericardium. And the final diagnosis also was acute perimyocarditis, ibuprofen given, colchicine given, and BBI, and patients showed dramatic improvement in the pericarditis, significant decline in biomarker of myocardial necrosis and dysfunction, and the normalization of high CRB. Third case, male patient, 25 years old, with no risk factor for coronary artery disease, referred from Saudi Airline Medical for assessment of a chest pain, and he was admitted because of suspected acute coronary syndrome. And you can appreciate here this ECG finding. There is a lot of differential diagnosis here, incomplete right boundary branch block, significant T wave inversion in V1, V2, and also mild SCT segment elevation. If you will look for the inferior leads, lead 2, 3, AVF, you can see early takeoff of the SCT segment in the inferior lead. So this is a lot of differential diagnosis. You can say Brugada, you can say posterior wall ischemia, you can say incomplete right boundary branch block. Cardiac enzymes done because of the chest pain and ECG change, and you can appreciate here significant elevation of high sensitivity troponin, 1,500, 159, CKMB, significant elevation 75, and the pro-BNP significantly elevated 5,659, and you can appreciate the marker of infections here. CRB showed 33 milligram per deciliter. Here, the echocardiography, you can appreciate there is no segmental wall motion abnormality, good left ventricular function, but there is hyperechoic pericardium clear. Angiography done as usual to rule out significant coronary artery disease, and the coronary angiography showed normal finding with no any obstructive coronary artery disease. Cine cardiac MRI, no wall motion abnormalities was detected if you compare it with echo. T2 image with fat suppression edema image showed increased brightness of the inferolateral wall, indicating focal myocardial edema, which indicating myocarditis, and delayed enhancement showed increase in the short axis and three-chamber view showing enhancements of the proximal inferolateral wall, indicating acute inferolateral focal perimyocarditis. Treatment as usual, non-steroidal anti-inflammatory drug in the form of ibuprofen in usual dose, colchicine and BBI, and the patient showed dramatic response. Another form of pericardial disease, male patient 26 years old with no risk factor, presented by atypical chest pain, ECG looks like normal, mainly T wave inversion in lead 3, troponin 54, CKMB normal, total CK normal, normal angiography, and you can see here the echocardiography, the posterior and the inferior areas of the pericardium, hyperechoic, no wall motion abnormalities. Cardiac MRI in Cine showed the same finding. T2 edema image by cardiac MRI in four-chamber view showing increased brightness of the septal wall and the epicoseptal segment, indicating myocardial edema, which is secondary to pericarditis. Delayed enhancement image of cardiac MRI showed faint myocardial enhancements consistent with acute perimyocarditis. Again, classic non-steroidal anti-inflammatory drug, ibuprofen, colchicine, and BBI. So acute pericarditis usually respond rapidly to anti-inflammatory therapy, including non-steroidal anti-inflammatory drug or aspirin. Colchicine improve clinical response and reduce recurrence and should be added to non-steroidal anti-inflammatory drug, either aspirin or ibuprofen. Corticosteroids are effective but should be avoided because of increased risk of recurrence. This is the levels of medical treatment on pericarditis. There is first level, second level, third level, fourth level, and fifth level. First level, which is aspirin or non-steroidal plus colchicine as dual therapy. If no response, corticosteroids plus colchicine. Third level, which is aspirin or non-steroidal plus colchicine and corticosteroid therapy as a triple therapy for non-responder to dual. Fourth level of treatment, use alternative drug like Imuran or intravenous immunoglobulin or anakinra to control the pericarditis if no response to the usual first, second, and third level. Fifth level of therapy, which is pericardiotomy, if there is no response to the above mentioned level of treatment. And this is the mechanism of action of anakinra, colchicine, Imuran, and intravenous immunoglobulin. So another case with pericardial disease, male patient, 55 years old, with no risk factor for coronary artery disease, but he is in the stage renal disease on regular hemodialysis. And actually, this patient, he presented by low cardiac output symptoms in the form of dizziness and near syncope with hypotension. These three hemodynamic symptoms, including dizziness and syncope, indicating decreased cerebral perfusion. And if it is associated with hypotension, so this is maybe the triad of early cardiac tamponade. Blood pressure was 80/60. Heart rate here was 45 beat per minute. No complete heart block. SpO2, 80% on room air. Neck veins elevated with positive cosmal sign. Increased abdominal contour, bilateral lower limb edema, and ECG showed low voltage criteria. And this is echocardiography. You can appreciate here it's a spot diagnosis of acute cardiac tamponade, secondary to massive pericardial effusion with RV and RA diastolic collapse. So this is case of cardiac tamponade. In short axis, you can appreciate here the left ventricle completely occluded during the systole, and in diastole, you can appreciate the RV and RA completely collapsed, indicating cardiac tamponade. So this is an emergency procedure. We send this patient immediately to the cath lab because the cath lab very close to the ER, and we did subcostal subxiphoid pericardio synthesis. And in this patient, we drained from the pericardium 1.5 liter of hemorrhagic fluid. Case number 6, male patient, 35 years old, with no risk factor for coronary artery disease, and presented by classic pictures of obstructive shock. Altered mental status in neurologically intact patient, low cardiac output symptoms, elevated jugular venous pressure, and severe hypotension. His echocardiography showed massive pericardial effusion, RV and RA collapse. Short axis, there is classic finding of cardiac tamponade clinically and by echocardiography. For this patient also, we did urgent subxiphoid pericardiocentesis with drain of at least 1 liter of fluid, and here you can appreciate the RA and RV collapse. MMO show classic RV collapse here in the stole. So cardiac tamponade is a life-threatening case of cardiogenic obstructive shock that can develop acutely or chronically according to the rate of accumulation of fluid in the pericardial cavity. It should be suspected in patient with tachycardia, elevated jugular venous pressure, and pulseless electric activity alternance. And for here, tamponade, it's a clinical diagnosis. When the patient came by hypotension, elevated jugular venous pressure, so you have to think about the obstructive shock, mainly cardiac tamponade. And if you will put the transducer by echocardiography, you can diagnose cardiac tamponade within few seconds if the echocardiography in the ER. You have to start the intravenous fluid, elective intubation for this shocked patient. And the only therapeutic strategy here, pericardiocentesis. And there is a lot, there is 3 axes for pericardiocentesis: subxiphoid with success rate more than 86%, mortality during the procedure less than 4%, major complication 4. And this is most appropriate axis for pericardiocentesis. There is another site for pericardiocentesis, which is intercostal space and apical approach if the subxiphoid not suitable for pericardiocentesis. So the site depend upon the largest fluid amount closest to the probe of the transducer and to avoid vital structure injury. Last case, which is case of curable heart failure, which is constrictive pericarditis. This patient, he's young, 35 years old, presented to the internal medicine clinic because of marked ascites and very minimal bilateral lower limb edema, which is called ascites precox. He was investigated as a patient of liver cell failure, and actually they cannot find any hepatological problem. Even endoscopy done, there is no varices. Abdominal ultrasound was done, only ascites, and so he was diagnosed as a case of liver cell failure. But he sent this patient to the cardiology. This is classic ascites, and if you look for lower limb of this patient, there is no edema. This is what's called ascites precox. Echocardiography was done, which showed classic finding of constrictive pericarditis, pericardial thickness, and you can appreciate mild dilatation of left atrium, right atrium, and the characteristic finding of the septal motion, which is septal shudder and septal bounce, and inspiratory variation or respiratory variation of mitral inflow more than 25%. And here also you can appreciate the middle E prime of medial E prime of the mitral annulus. It's bigger than the lateral annulus because in the septum there is no constriction at the level of the septum. So the medial E prime, it will be normal or higher than the normal if you compare it with lateral E prime. So constrictive pericarditis was here the right diagnosis, no liver cell injury, and this patient was suspected as a case of constrictive pericarditis. And the etiology of constrictive pericarditis could be post-radiation, tumor, cardiac surgery, or post-operative hematoma. Symptoms: right side heart failure, ascites, edema, abdominal pain, jugular venous elevation with cosmal sign, rapid wide descent of the GVB, pericardial knock, which is characteristic for constrictive pericarditis, and you can see associated pleural effusion. Echocardiography is often diagnostic for constrictive pericarditis. Echo key findings include abnormal septal wall motion in the form of septal shudder and bounce, tissue Doppler velocity that are highly higher in the septum if you compare it with lateral wall, increased respiratory variation in the mitral inflow velocity more than 25%. And this is the classic on the left side, the normal finding, and in the middle, which is cardiomyopathy. So you can see medial and the lateral E prime decreased, but in constrictive pericarditis, the medium B prime normal or exceeding the normal if you compare it with lateral E prime. If we are lucky, we will find this calcification in CT chest for patient with constrictive pericarditis. So constriction can be diagnosed frequently by history, physical examination, and imaging, but cardiac catheterization remain the gold standard for diagnosis of constrictive pericarditis. And this is the classic finding in constrictive pericarditis during cardiac catheterization, which including equalization of filling pressure, enhanced ventricular dependence, intrathoracic interventricular dissociation, and this is hemodynamic assessment showed elevated and equalized all diastolic cardiac chamber in the right side, right atrium, right ventricle, pulmonary artery, left atrium, left ventricle. So all diastolic pressure are high and equal and elevated. So the diagnosis of constriction should be aggressively looked for because it is a reversible cause of heart failure. Think about constriction for patient with dyspnea and or dominant right heart failure and normal ejection fraction by echo. Cardiac constriction important for diagnosis because it's a curable diastolic heart failure. Treatment of constrictive pericarditis, definitely surgical pericardiectomy, and we send our patient to the surgeon and he did pericardiotomy, and the patient showed marked improvement, no ascites, no limb edema, and now 2 years after the pericardiotomy, the patient enjoying his life. Thank you so much for your attention.
Wow, I must say that was very good. What's very remarkable is all that patients is very young, some of them in their 20s.
Yes. The problem here, there is a lot of confusion because the patient with pericarditis, they are presented by chest pain, ECG changes, elevation of cardiac enzymes, elevation of pro-BNP. So even if the patient he is young, still we have a lot of marker of myocardial injury, not myocardial necrosis. So you have to rule out coronary artery disease to be sure 100% we will not miss underlying significant coronary artery disease.
Anur, you can speak.
Thank you. That was an excellent overview and a fairly thorough overview of pericardial disease. And what impressed me even more was the correlation that you showed us and the manifestations of the imaging findings, echo, MRI, CT, and the others in relationship to the clinical syndrome that you were dealing with. Very impressive indeed. The question I have is, you showed us that when it came time to deciding about ischemic disease or infarction, you proceeded directly to invasive angiography, even in fairly young patients. I mean, why did you not just do a CT angiogram? And with the CT, you also had so much more information about the pericardium, the myocardium, the valves, and everything else.
Excellent question, Dr. Al-Noor. And I can tell you in this patient, and you know, and all of you know that the resolution of the CT, it depends upon the heart rate. So this patient presented by increased inflammatory marker, and there is tachycardia, and you cannot decrease this heart rate acutely to the level of 60 beat per minute, because you know the image resolution for coronary, it depends upon the diastolic time. So if there is prolonged diastolic time, you can get an excellent demonstration of the coronary anatomy. Most of this patient, because of the associated infection and the elevated heart rate, if you will send them to the CT, you cannot get good quality image for the angiography, for the CT coronary angiography. I know CT angiography, we can solve this problem, but you know, because of time, it's a very important. So we decided to do conventional coronary angiography, because our CAS lab, it's a very close to the ER, and it will take only 10 minutes to do the angiography. If you will prepare this patient for CT angiography, it will take time to give beta blocker, to decrease the heart rate, and to do the CT angiography.
Thank you.
I have comment. Samir Rafna, can I say comment?
Yes, please, Dr. Samir. أهلا بيك.
أهلا بك. محاضرة ممتازة. I published paper about case of pericarditis diagnosed by mistake as infarction. Catheter was done, found significant lesion in right coronary, and put stent, and they gave Plavix and aspirin. The effusion, the pericarditis turned into effusion and constrictive, and eventually the patient died. So I published, take care to give Plavix and aspirin to a case of pericarditis like this.
Thank you. So if there is no more question, I would like to thank you all and for inviting me to give this pericardial disease case-based approach. And I hope it was up to the point.